You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. In this episode of The Dish on Health IT, we're digging into how the Massachusetts Health Data Consortium, better known as MHDC, is helping its members navigate compliance with the CMS 0057 interoperability and prior authorization rule. Host Tony Schueth, CEO of Point of Care Partners, and co-host Ross Martin, medical doctor and senior consultant at POCP, welcomes special guest Denny Brennan, executive director of MHDC. Together, they'll explore the MHDC community's progress, challenges, and important exploration of work outside the scope of CMS 0057, including efforts around pharmacy prior authorization. We hope the discussion sparks new ideas and illuminates new perspectives. Have suggestions for future episodes? Visit the podcast page at POCP.com under the Insights section and share your thoughts by submitting a form.
Welcome to The Dish on Health IT. I'm Tony Schueth, CEO of Point of Care Partners and your host for today's episode. On this show, we serve up fresh perspectives and candid conversations on the challenges and opportunities shaping health IT. Today, we're digging into how the Massachusetts Health Data Consortium, MHDC, is helping its members navigate compliance with the CMS 0057 interoperability and prior authorization rule. We'll highlight the progress they've made, discuss some of the challenges, and explore important work outside the scope of CMS 0057, such as pharmacy prior authorization. While this work is happening in Massachusetts, it deserves national attention. We should all be learning from each other so that we can avoid pitfalls wherever possible. Before we get started, I want to welcome my co-host, Dr. Ross Martin, Senior Consultant with Point of Care Partners, and our guest, Denny Brennan, Executive Director of the Massachusetts Health Data Consortium. Ross, why don't you kick us off with a quick introduction about yourself before we bring Denny in?
Happy to do so. Thank you, Tony. I'm reporting from Berkeley Springs, West Virginia in my yurt. And I'm a former obstetrician who, long time ago, about 30 years ago, decided to take a plunge into trying to fix healthcare, starting with business stuff, and then dug into medical informatics, did a fellowship in that in the late 90s, and have spent pretty much all of my career working on the intersection of policy, strategy, business, and the technology in healthcare. So that has been the interstitial space I've worked in for about 30 years. A lot of different places: Pfizer, Bearing Point, Deloitte, the American Medical Informatics Association, CRISP, the Health Information Exchange. And in terms of prior authorization, you and I actually got a lot of start back in the mid-2000s working on concepts around how to do prior authorization electronically, which has blossomed into a lot of stuff since we led that project many, many years ago.
Wasn't it a high school science project or something like that?
Yeah, it felt like it. It was a long time ago.
Thanks, Ross. Now let's get to our guest. Denny, welcome back to The Dish on Health IT. It's been a while since we've had you on. Why don't you start by telling listeners a little about yourself and how you came to your current role with MHDC?
Certainly, and thank you for having me. I've been with MHDC now for 13 years. I joined the company in 2012, before which I spent my career in health IT exclusively, working with providers predominantly, but also with distributors, payers, technology companies in a number of areas, strategic and operational. The work that I've done in my time at MHDC has really been built on the experience I gained working with multiple sectors within healthcare with a focus on technology. And with MHDC over the last 13 years, I've had a chance to refine those in a dedicated community, which is an extraordinary opportunity and something I've enjoyed a great deal.
And the work you're doing is truly impressive. So let's level set with our audience who may not be as familiar with MHDC as we are. Please tell us about MHDC, its mission, and the current focus of your work.
Certainly. MHDC is a longstanding not-for-profit corporation in Massachusetts. We were founded in 1978. So we are approaching our 50th anniversary in just a couple of years. We introduced, among other interesting factoids about the company, we introduced our members to the internet. We were founded before the internet. We were founded when people were moving data by taking large tapes from computers from one place to another and moving data literally rather than electronically. Obviously, over the years since, we have been through everything from the internet to HIPAA to meaningful use to ICD-10, and now we're into interoperability and helping our community take advantage of the fact that because we have been working together for so long, and because MHDC has established a high degree of goodwill and trust among our community. Our members are hospitals, health plans, physician groups, technology companies, regulators, both state and federal, as well as associations like the Hospital Association, Health Plan Association, and the Medical Society. So we bring everybody in healthcare together. And our mission is to use that consortium approach, that collective gathering of different perspectives, different segments of the market, to accomplish things that are too difficult for one organization to do on its own. These are things that usually involve scale economies or usually involve, a large number of participants needing to work together in a particularly orchestrated way. A big example being moving from ICD-9 to ICD-10. We were able to convene 93 organizations to come together and agree on a common approach to moving from 9 to 10. And now we're involved, as we'll be talking about, in helping that same Massachusetts community move forward with an interoperable health system and a single network that we call NEHN Fire that will mirror the NEHN EDI exchange that we currently operate. But NEHN Fire will enable all of the plans, providers, and other caregivers in our community to use the most modern technologies to share information for prior authorization automation, as well as for quality measurement. So we're off to a great start. We have a number of health plans who have already committed to participating in our NEHN Fire collaboration, and we anticipate having more health plans and more providers signing up with us by the end of the year.
It's really exciting, and the work that you've done over the years has been super valuable to the country. And I just want to thank you for that. Thank you for that overview. But let's move on and get into some of the details on this that we're going to talk about today. Prior authorization. Denny, why take on prior authorization and CMS 0057 work at the state level? Why is it important to do it at the state level?
Well, the reason it's important to do it at the state level, Tony, is because we know everybody. Fundamentally, healthcare is a national challenge, but it's a local business. It's a local industry, and it's highly regional. You can go from one state to another, and you will encounter a completely different health system with different players, different hospitals, different insurers, different state regulations. So working at the state level provides an advantage that is difficult to harness at the national level, which is, as I mentioned, we have all known each other for a long time. We have all worked together. We've established a level of trust and a level of expectation that we can accomplish things that might be hard to get started on at a bigger national or large regional level. The other reason that we've tackled this automated prior authorization is because, one, it's making a lot of noise. It's upsetting clinicians, especially physicians, for whom, securing the services they need under tighter utilization management restrictions than they faced before has become a really burdensome process. And no physician can be expected to know every health plan's separate policies and criteria for approving a prior auth. But in some cases, we have now a system where those physicians are simply filing prior auths the old-fashioned way, fax, telephone, whether they need them or not, because the system is so confusing. There is this effort, just in case, to file prior authorizations and to try to get work around the system, which is so difficult. The second reason we chose prior authorization is because it's it's one of those efforts where improvements benefit all parties. Health plans benefit by reducing the amount of abrasion that the prior authorization process creates by working with physicians and hospitals and other providers to perform this task in an automated fashion, and to do so with much less friction, much less abrasion than has been the case. So everybody benefits, patients, payers, providers, from making this process work. Third reason, it saves a ton of money. And we know from research done by McKinsey and others that, upwards of a quarter to a third of healthcare expenditures in our country are devoted to administrative functions, to the administration of healthcare. And prior authorization is a big part of that. It's not the only part, but it's a big part of that. So this is an area where if we do it properly, and we do it as a state, and we do it as a not-for-profit, the benefits of that, the savings in dollars, have a much greater chance of going back to the premium and reducing premiums for employers and employees and customers on our exchange, reducing the burden on our government payers by lowering the cost of operations. The last thing I'll say, we did it because we thought it was a really cool thing to do. We really thought, this looks like something, given the great work that you guys have been leading with HL7 Da Vinci, and we have your team working with us on this. The great thing about this is we have cookbooks on how to do this. The implementation guide that's coming out of HL7 Da Vinci. And I've always liked taking things apart and putting them back together again. Not that that's what motivated us to do this, but my colleague Dave Delano, who used to manage the EDI business and is now working with us to help us run this process going forward. When we were looking at what can we do with FHIR and what can we do to make a real benefit to our community, we said, let's do prior auth. It sounds like if we can automate this, not only will it make a great impact, be a great benefit, but it's also kind of a great project. It's a very exciting thing to automate, and we're enthusiastic about that.
Well, we love to work on cool projects, but we also really love to work on projects that make a difference. And as you mentioned, as someone that's insured, I love to reduce premiums. So I love that you bring that into it.
Ross, it's a big deal.
Ross, Denny talked about doctors, and from your perspective as a physician and as someone who's sat really in a lot of different seats in health IT, and was also kind of a visionary and someone that really saw prior authorization as a challenge to getting therapies to patients. And there was an opportunity to sort of streamline and make it operate more efficiently. What's your take on all this?
I think about my work after the HITECH Act was passed and working with health information exchanges all over the country to get people to the table. And one of the things that's very different about what's happening in Massachusetts with the Health Data Consortium, they've had 50 years almost of working together to work on various problems. And there was such a problem in some states with the intense competition among providers, and everybody was kind of seeing everyone else as an other, and just getting folks to the table. Even though a lot of money was being thrown at health information exchange, for example, it still didn't necessarily equate to progress because there hadn't been that established drive to work together and solve problems. And I loved kind of the framing of the problem-solving aspect of this. It reminds me of this Columbo episode from way back when some guy from Mensa had murdered somebody, and Columbo got him to show the trick of how he made it sound like a body fell at a certain time when the guy was already dead, because it was a puzzle right in front of him and he just had to solve it. And so I think that that's a real good analogy of thinking about how, when you bring these things to people and just say, yeah, but if we just work this out, look at the puzzle and let's work this out together. It's pretty irresistible to a certain type of person. I don't think that not every state and every jurisdiction has the advantage that MHDC has had of having this very long-standing relationship on this. But there are always places of that. And if you can find those areas of mutual trust and places that you've had experience of solving a problem together, I think that is one of the key pieces, is building that repeated history of working together to solve problems. And it's all about aligned incentives. If you can't get those incentives aligned in some way, and this is an area, frankly, where yes, there will be money saved, but there is a real incentive problem with prior authorization. Fundamentally, prior authorization is as a barrier to getting, prescribing an expensive drug. The inefficiency of it is a feature, not a bug for the payers in some ways.
Absolutely. Denny, what do you think? Are you guys, problem puzzle solvers? Is that what MHDC is and what you are? And what are some lessons learned as you've sort of taken on this puzzle and this challenge?
We are puzzle solvers, but I think the way we go about solving puzzles, Tony, is, we're a consortium. I mean, we're a small company. MHDC as a company is a small company. We're successful. We're growing, but we're still a small company. And the power of an organization like ours is this, is the consortium aspect, which is, we bring these people together. We recently had a deep dive into prior authorization, into how the workflow would operate under automation, and how people would need to organize their systems, how people would need to think about when to activate or initiate the prior authorization inquiry, as an example. And we have tons of ideas, but our community has even more. So when we bring that community together, we had the steep dive I mentioned. We had about 60 representatives from multiple health plans, multiple providers, the state. We had a number of people in the room. And we basically laid out a framework for how the prior authorization process would work in our minds, just a sketch based on the work that you have been leading with Da Vinci and the implementation guides, and the community fills in the rest. The community comes back to us and goes, well, we could do this here instead of what we're doing now, or we could work more closely with this health plan if we're a provider, or this provider if we're a health plan, and we could do some things differently. We might even change some policies or some criteria that we currently have if they're really out of tune with the rest of the community. So the great problem solving thing about us and what we do is that we can sort of, if we're good at it and if we're thoughtful, we can activate and excite our community to help us think these problems through and come up with decisions and recommendations that they have their own, that they themselves have made. And that gives them much more stickiness. It gives them much more resonance among a community when they sit down and talk to each other. These organizations have a very difficult time, even in a place like Massachusetts, where we do talk with each other on a fairly regular basis. It's very hard for a payer and a provider to get together and go over this in any detail. And certainly they can't do it with all their trading partners. So we provide a vehicle for them to share ideas and for them to participate in the construction of the solution. And that's where we get most excited. It's fun to think about going up into the smoke-filled room and coming out with your new Rube Goldberg invention that will fix everything. But the reality is, if you go into that room that is not the smoke-filled room, but that room that is where your community is sitting and working with you, you can accomplish things that you never thought you would accomplish when you went in. And that kind of momentum is what really excites me and excites the members of our team, is when our members say, I get it. We can actually do that, but we could also do this a little better than we're doing it. What do you think, fellow payer, fellow provider? And that builds relationships, which ultimately is at the heart of what we do. It sounds a little cliched, but these people know each other, but they really want to work more closely with each other. So if we can build on those relationships and keep our commitments, that gives us the kind of momentum that is otherwise very difficult to activate. And we've got that. So it's really the community that gives us that excites us and gives us more ideas and tells us where we could be going off on a tangent. We should think differently about something. So I think that's what makes this most exciting and makes us feel like we're able to do the kind of exciting work that we can, is because we can get the people in the room together to help influence and shape what that future will be, which has a great impact on the likelihood of success. Very positive impact.
Powerful. Rosh, do you have any thoughts on this?
I agree, of course. I go back to the alignment of incentives and the trick about that, and getting people to think about. I've always been a patient advocate. It's always been something that people have known me in the industry for thinking about this. That when we focus on having a patient and what the impact is for them and this process. This is not the healthcare system we would have designed if that were truly our focus. But if we look at it through that lens all the time, and it's always hard to get patients in the room with this because everybody else has somebody with a financial incentive to go to the meetings and to spend the money on doing the homework and all that. But if we can get that patient voice in there, that can be a very impactful part of this process.
Without a doubt. One of the things when I facilitate, I always remind everybody is that we're all patients in here. So we can wear two hats. We can wear the hat of our organization that brought us in, but we can also step back and think as patients, or as, in my case, a spouse or a father, and how it impacts, my family. So without a doubt, we need to look at it from a patient's perspective. Let's change gears a little bit and let's talk about FHIR adoption. Why do you think adoption has been so slow, Denny?
I think slow adoption is the way things work. I think you have to show through slow adoption success and impact, and then adoption accelerates. No one's going to jump into a new technology wholesale without seeing, especially in an industry as conservative as healthcare, no one's going to adopt a new technology unless they've seen someone else jump into the water first and tell them that it's fine in the water. You can come on in. But I think one of the things about FHIR that was difficult was the fundamental idea of patients being able to access their health information in real time was unheard of until the 21st Century Cures Act, where patients having access to their health data was a central tenet of the 21st Century Cures Act. And before that, we had systems, electronic health record systems, which, were doing what their customers were expecting of them, but also were doing what was good for their business. We're keeping that information tightly contained, and so tightly contained in some cases that health systems had hard times communicating with other health systems. But the 21st Century Cures Act kind of blew that up and said that is called information blocking. Patients have a right to their information. And then with that sort of hurdle at least partially cleared, the question became, how do we do this? And the power of FHIR and the power of real-time RESTful API interoperability is that you can bring together systems that are completely disparate and they can communicate with each other. When the JSON report came out 10 years or so ago, the JSON report said, your industry is woefully behind where other industries are that have the same challenges that you do. Different segments, sectors have different technologies, but they're communicating with each other in real time. If Walmart wants its distributors, its wholesalers to do things a certain way when it comes to technology, those wholesalers will do that thing. They will follow what Walmart recommends. And we've seen in other industries the impact of RESTful APIs, but we don't see it in healthcare, where we have this historically somewhat feudal structure of isolated repositories of data that may be beautifully curated at the institutional level, but not available to anybody else. Patients needing access to their information was really what ignited that. But also it opened up the possibilities with new technology like, the HL7 FHIR work that you're doing with Da Vinci. It also created the ingredients that you need to write cookbooks, technology cookbooks that say, here's how you do this. Here's how you connect to a different system. Here is how you share data. Here is how the data are standardized and orchestrated for that. So that was really what when we saw that coming out, and that goes back to, the first Trump administration and the first attempt to put e-prior authorization on the board as a regulation. It was too late to become a regulation then, was stalled in the Biden administration for a period, and then picked up near the end of the Biden administration and formalized. But people knew that if they wanted to be able to do this, they needed to have a technology that would have moved data at a granular level, individual data elements from one place to another with a high degree of security, a high degree of timeliness, and a high degree of replicability. You could do this again and again and again. And we saw in that technology, we saw the opportunity and in the work that has been done to assemble those implementation guides, we saw the opportunity to do something we haven't ever been able to do before. And as I mentioned, prior auth is something that everybody said it would be great if we could do this better. It would be great. We're not talking about getting rid of it. I mean, certainly this is going to enable people to see prior auth much more clearly than they've been able to see it before. And I expect there will be changes structurally to prior auth in the future as a result. But right now, we can routinize this complexity. As complex as it is, we can make it, part of standard operating procedures between payers and providers and patients. So I think the combination of patients' frustration, outrage at not accessing their data and not being able to do it, plus, a serious push from Capitol Hill, serious push from the feds, which, healthcare is a regulation-driven industry. Nothing moves healthcare faster than a regulation. With a combination of those and the work that's being done by HL7 and POCP to build the implementation guides for this, we saw that as a golden opportunity to start making this happen.
Well said. Ross, do you have anything to add? You've been in this business for a long time, and you saw sort of fire in the birthing room, and you've seen it grow.
I actually dropped out a little bit from the standards development stuff right at the beginning of FHIR, but I knew a lot of the players that were building it, and I remember reading that this was emerging and saying, finally, because if you think about, I spent a couple of years trying to get my head around version 3 of the reference information model in HL7 and how all of it was so intellectually pure and unimplementable. And then you get to the FHIR approach with the Graham Grieve and others initiated. And the beauty of it as a solution is it uses the same thinking that everything on the web was built from. It's the application programming interfaces that do this really basic stuff that anybody who can develop a website, with tools that they can implement FHIR with a very little bit of additional education on how to implement it. And as Denny said, there are a lot of cookbooks coming out. We're almost at risk of too many of them without, there is a growing issue of the proliferation of the ways to do this is growing very quickly. And so I think we're at this place where we really need to start implementing and getting common methods built into our architecture. And you say it's a slow adoption, but I think it's been a curve that we recognize. Maybe it's a little bit slower, but if you look at, I know Epic released some data recently where they'd shown going from, back in 2016, 5 organizations with FHIR to almost 500 as of the end of 2024, and thousands of endpoints, and tens of thousands of facilities using it, and that's just one, albeit a very large implementer, but one implementer of this. And so you see, just like every type of adoption curve with the laggards and the innovators and stuff, you're going to see this bolus of stuff, especially once I think people really understand how doable this is and how repeatable it is, and not just for prior authorization, but if you think about what prior authorization is at its fundamental, it's asking questions and saying, it's giving criteria that are really clinical decision support wrapped around a financial coverage question. It's the same stuff that you can use for, CDS hooks for doing not prior authorization, but clinical decision support. You can do the exact same thing for prior authorization. And I do think that that's a potential role for some federal guidance, and perhaps if there's not federal guidance soon, some state guidance that says, in the absence of a decision around this, picking, for example, HL7 Fire to be the thing that asks clinical questions of data repositories, be it an electronic health record or a health data utility repository or a health information exchange, that is the thing that you standardize to ask the question. It can still be in NCPDP script for pharmacy prior authorization, because that's been named as a standard for that, and that's fine. But include the method within the query for the computable part of it to ask the question using HL7 Fire. I think that is if I were, the grand wizard of interoperability, that's what I would push for and make happen.
It's interesting that you bring up pharmacy prior authorization. It wasn't included in CMS 0057, but MHDC has been exploring how to bring it into the state initiative that you have, Denny, that you described. Why is pharmacy PA so important to your members? And do you think it should be a higher national priority?
First, I think it should be a higher national priority. I think for many physicians, and we have to sort of think about, when we think about prior authorization, we have hospitals weighing in because they have to get authorization to move patients from one level of care to another, for example. But the overwhelming majority of prior authorization experiences happen between physicians and health plans. And a huge number of them happen with primary care, dermatology, oncology, where the need for prior authorization for drugs is experienced far more often and far more disruptively than the prior authorization for services. Physicians can get a referral for a patient to a specialist, which some people sort of think about as prior auth, but it's really not. It's a simpler transaction. It doesn't require FHIR to do a referral. So if I need to see a specialist, my primary care doc can say, I can get you an appointment with a specialist and make that, lay that path for you. That's pretty straightforward. But if a physician needs to prescribe me a medication, in all likelihood, I'm going to show up at the pharmacy and I'm going to find out that medication requires prior auth. And I'm thinking, well, my doc prescribed it. Why isn't it approved? Well, the pharmacist is supposed to do that. And we looked at this sort of maelstrom, this kind of, all this activity around more actors. There are more actors involved in pharma prior auth than there are in medical services prior auth. We have PBMs, delegated vendors for health plans who are responsible for drugs. We have pharmacists, and that the orchestration of those parties is more complex. But the reality is that pharma prior auth is what most of our docs complain about. They don't say, I'm really having a hard time getting an MRI for my patient. They have to go through prior auth, but they don't do that as often as they try to get a prescription. And this is an area we felt like, we could solve the medical prior auth problem, but if we didn't show that we were making in good faith and a real effort to solve the pharma prior auth problem, we would have a lot of unhappy customers. We'd have a lot of people in our community who would go, wait a minute, it looks the same as it did before. I'm still getting, dinged, and I'm still having patients and pharmacists calling me up and saying, why is this drug being prescribed? Then I have to call the PBM and go through a conversation with them. And we said, we have to fix this. And we knew that POCP has this in their DNA. We knew that you guys are really good at this. And we thought, this may not be a technology problem. It doesn't smell like a technology problem. It smells more like some technology, some sort of operational orchestration. Which way do we do this among many ways? It sounds also like because there are more parties, we have to be more thoughtful about what the workflow looks like and how to make it happen. But we didn't know what we didn't know. So we said, if we're going to solve prior auth as a whole problem. We have to work on drugs. We have to do them even though they're not under the CMS 57F final rule. They're likely, in all likelihood, they're on the federal, sort of list of possible and likely legislative or regulatory targets. We said we need to get ahead of this so that we can talk to our community about what goes into proving, fixing the prior authorization for drugs process. So we worked with you guys for several months to kind of just get a view of the market. Who's saying what about this? What's the problem? How can I define this problem well enough that I can begin to understand what solutions might work best? But we knew from the beginning when we started our prior auth work that we had to deal with pharmacy because it came up in our interviews, came up in our consortium meetings, and we did not want to leave that behind. So we wanted to show our community we were making an effort. And as the technology landscape settles and people start to figure out how this will get done, we want to be ready to do it. We don't want to then go, oh, okay, how do we do this? We want to be ready to know how to do it at the time that's that it's required and that people are ready for us to put it into implementation. So it's a big part. It's much more complex, but we're excited to be able to get started on that and in anticipation of where regulation is likely to lead us.
It's really smart, and I want to commend you again for taking that on. Ross, you and I were involved really in the early days of prior authorization on the pharmacy side. You were a visionary in that world, but you also just worked on this project for Denny. And I'm just wondering, what are some of your key takeaways from the project that you just did? Where is pharmacy prior authorization? Where are the roadblocks, and how do we get things moving forward again?
Yeah, when we worked on this question about how would you do this electronically back in the early 2000s, probably it was like 2003 to 5, I guess, 3 to 7, I guess, when we were really doing this. It was, this wasn't really happening. It's kind of like you look at the e-prescribing curve. It's very similar that there were so many obstacles to it. But if you really dug into the technology, it was very possible to do, albeit with the named standards of the time, it was very extremely clunky and you wouldn't want to do it that way. And I think we made some progress in getting folks to say, let's think about this differently. And if you look, there's a lot of electronic prior authorization happening now. It's just not happening in the optimal way. It's still causing a lot of pain. So I want to, go back and commend, like you just did, the MHDC for doing the work of asking the questions, of having the conversation initially to say, what don't we know? Because I felt like I knew a decent amount about prior authorization, and yet doing these interviews was really enlightening, especially talking to providers. Like one simple thing, when they talked about the year-end crunch that happens because the prior authorizations typically at the beginning of the benefit year get renewed, and at the end of the year there's this, oh, who knew? We have to renew this thing, and they've got their new benefit. They've got renewed with the same payer or with a new payer at the beginning of the calendar year, and suddenly there's this onslaught of renewals that happens, and it's an incredible burden for providers. And I hadn't been aware of that. I think if I had had any conversations with people, I would have known about this. But that was just an example of something that once you talk to all the stakeholders, you've got this vision in your head about, oh, I know the solution because from where I sit, I can see the way. And yet you get up and you talk about it with a bunch of people and you find out, oh my goodness. So just the other day, yesterday, there was NCPDP, the National Council for Prescription Drug Programs, held an e-prior authorization roundtable up in Philadelphia. And I got invited at the last minute, thank you, Tony, to get in that room. And it was just a 2-hour meeting. And the thing I want to reflect about from that was, at the beginning of the meeting, they asked a question, do you think we can get this accomplished with the existing technology that we have today to do really effective prior authorization? And they had a polling tool. And about half the people said yes, and about half the people said no. After 2 hours of deep conversation about this with stakeholders from every part, and these are people who understand a thing or two about prior authorization. These were people, these were informed people. At the end of it, it went down to like 20% that thought we could do it with the existing technology. And it's not that with the existing structures, it's that this stuff is still pretty complicated and there's a lot to think about. And my point is that everybody got enlightened about all the different ways this still doesn't work the way it should. And it means that we have to continue the conversation and do it collectively in order to really move us forward. There is not a single stakeholder in healthcare who can fix this for healthcare. It has to be as all of us. And that's why I think, organizations like MHDC have a first mover advantage. And what I love too about what they're doing is they are very willing to take what the experiments and the progress that they're making within Massachusetts and sharing it with the rest of the country and showing this is the way, this is how to go forward and make this happen. And then if federal regulations come in and more federal programs or just more enlightenment from other places, I'm sure that they're going to, pivot as other places show other solutions and ways of doing it. But they're not waiting around for this to, for somebody else to fix the problem to solve it. And I think that is something that you see over and over. Entities, from Indiana and Regan Street back in the early days of trying, building Loink and things like that. So many other products. Utah has done that. Massachusetts has always been on the forefront. And Maryland with the health information exchange stuff that they've done through CRISP. These are all places showing that this is all possible. And then people will pick it up from there.
Well said. And Denny, you really do. MHDC really does show that it's possible. We're now really at a point where we need to close. And what we always do is ask our guests to leave listeners with a call to action. So Denny, I'm going to go with you first. If there's one thing you'd like everybody to do better or understand better, start doing tomorrow, what would it be?
The thing that springs to mind, Tony, right off the bat is there's a place to be competitive and to play a zero-sum game. And there are places where you don't do that. And between payers and providers, the contracting process is going to be, at best, it's going to be sort of intense and tightly competitive or self-interested. And at worst, it's downright, adversarial. But when you want to get something done that requires payers and providers to work together, they have to kind of leave that mindset behind. And they have to do this sort of split between where do we need to be tough competitors and tough negotiators, and where do we need to listen and figure out how to do things together. And we see that receptivity. We see that being the way in which our community is working. We know when they get to negotiating contracts, there's a different set of principles, there's a different set of personas and activities that are done. But when we're trying to build something that requires collaboration, we're seeing that these organizations are able to do, to do these two very separate things that require entirely different perspectives and do them well. So the first thing I would, the call to action I would leave to folks is this is not contracting. This will result in better contracts in the end, but this is not contracting in and of itself. This is collaborating. And collaborating is different. And bring people who are collaboratively minded, who want to fix the problem, want to talk to the payers, really want to talk to the providers. The providers want to talk to the payers, but sometimes they're stuck because they're used to that adversarial relationship. So the one thing I would leave with folks is there's a place for that in a civil negotiating model for contracts, but getting things done that are innovative, getting things done that require cooperation and integration and interoperability require collaboration. So split those and focus on collaboration.
Well said. Ross, from your perspective, what's your call to action?
Just building on that, one example of that, figure out the line between competition and collaboration. You think about asking a question of the data, has this drug ever been used, or does this patient have this diagnosis? There are the place that you don't compete is how you ask that question. Yes, every payer is going to have a different set of benefits about what their thresholds are for how many months of therapy can somebody have before it's shown that it's failed and they need to move to something else, or just any number of things that they can compete on, but not on asking the question. That's finding those things are super important, and that's just one example of one. I think the other call to action is for all stakeholders to really figure out that involvement in the standards development process and the harmonization of standards is a long-term play that they have to stay involved in. The designated standards maintenance organizations, the DSMOs that were named under HIPAA, they're now being called to one of our colleagues at Point of Care Partners, who leads represents HL7 in all of this, Alex Goss. They made a great presentation at the WEDI meeting this week in DC about their requirement to basically get along in the sandbox together, and how this is sort of being revived, and we need to be thinking about this. That's an example of a great opportunity right now for all stakeholders to really dig in and get involved in that. And it takes commitment on things that are not going to pay off this quarter. And that's the hard part, especially for for-profit organizations that don't always have a long-term view. They have to get involved in this stuff because it's going to kill them in the future. And if they're not at the table, their perspective is not going to be recognized in this, and they can't rely on other stakeholders to do it. So it's super important to get involved in HL7, in NCPDP, in X12, in the DSMO process of collaboration on this. Those are kind of my two big takeaways.
Well said. Denny, thank you so much for joining us and for sharing the important work you and your team are doing at the Massachusetts Health Data Consortium. We're so honored to be working with you on this important work. And Ross, as always, thanks for co-hosting and sharing your insights on this. For our listeners, you can find this and other episodes of the Dish on Health IT wherever you get your podcasts, including Spotify. We're also on Healthcare Now Radio. And if you enjoyed this conversation, share it with a colleague and be sure to subscribe so you never miss an episode. Until next time, Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with FHIR accelerators? Email us at interopoutlook@pocp.com to learn more about our Interoperability Outlook subscription monitoring service.